Evening, everybody. Welcome to the Monash University webinar entitled From the Frontline, Using Nurses' Diverse Experience During COVID. I'd like to begin by acknowledging that I'm hosting and recording this webinar from the lands of the Bunurong people. I also acknowledge the traditional custodians of the various lands on which you all live and work today, and the Aboriginal and Torres Strait Islanders, people participating in this webinar. I pay my respects to elders past, present and emerging, and celebrate the diversity of the Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. This evening's event is being delivered by Monash University School of Nursing and Midwifery. I am Professor Deborah Griffiths and I will be your host this evening. I am Head of Nursing and Midwifery here at Monash University, and we are very dedicated to educating the next generation of nurses and midwives in our innovative and world-class programs. Something that many of you may not be aware of is that our academics are often educators, practitioners and researchers. We work within a discipline that is continually developing and evolving. As a registered nurse and registered midwife of many years' experience, I think it's really important to highlight the difference in education preparedness of our profession from, say, 40 years ago when I began my career. The current tertiary experience of the profession links nurses and midwives closely with research and the utilisation of evidence as the best way of informing practice. This was not really the case when I began my career. We were less questioning and independent of thought. Today's nurses' skill set is really broad to ensure they are equipped with an ability to make critical clinical decisions and operate with a level of insightfulness and autonomy, as well as a balanced degree of empathy. This is what makes a wonderful nurse. This webinar tonight is intended to highlight the diverse and important roles of nurses, which are often undervalued or not necessarily seen or understood by our community members. So we want to provide you with insights from our expert panellists who are nurses and academics, and this is via the lens of the current pandemic, which crashed through our lives right back just on the back of the disaster earlier this year, on the back of our disastrous bushfire season. So that's what we would like to do tonight, to try and share with you some insights from the nursing frontier. The format for this session is for each speaker to present for approximately 7 minutes. Then we'll move into a Q&A session. We have received some questions already from our audience in the lead up to this webinar, and we hope to get these and to other questions that you may upload anytime throughout this session through our Q&A function on Zoom or via the YouTube live chat. So without further ado, I'd like to introduce you to our panellists. There are 4 speakers this evening, and I'd like to begin to introduce you to Vanessa Clothier. Vanessa is a nurse practitioner in an emergency department, as well as the coordinator of the Master of Nurse Practitioner here at Monash Nursing and Midwifery. Vanessa this evening is going to share her experiences of what it's like to work in a busy hospital emergency department and how infection control and patient management practices have changed to manage this highly infectious disease. Vanessa will also share some personal insights regarding what it's really like being a clinician on the front line of this pandemic. Thank you, Vanessa.
Thanks, Deb. I feel very privileged to be included on this panel and speaking to our webinar audience, made up of both nurses and non-nurses, but all with an interest in this space. I need to start with a disclaimer. The views tonight I express are my own, and they don't represent the organisations I work for in industry, nor those of Monash University. Additionally, I'm not speaking on behalf of all emergency nurses. This is simply one clinician's lived experience. It's truly baffling to think that only a year ago, COVID-19 was not a term we knew. None of this had happened, and we had no idea that it was on its way. It can feel like it has been with us forever, especially for Victorians who feel like we've been in lockdown forever. Some days I look around the emergency department floor at my friends and colleagues in full PPE and think, how did we get here? How can this be our new normal? And what is our future going to look like? At the beginning of the year, we recognised we're in a very privileged position to be able to watch and learn from our colleagues in the Northern Hemisphere and their COVID experiences. We had time to prepare ourselves for the potential tsunami that could come our way. In January and February, my ED colleagues and myself watched in utter amazement as we saw how some of the ED departments overseas were becoming overwhelmed with patients. I don't think I'll ever forget the vision of refrigeration trucks parked outside New York emergency departments to cart away their dead, or that in Madrid in Spain, they turned an ice rink into a morgue. ED staff are very much accustomed to having busy shifts. I often think that what we do in emergency departments, it's a craft. We turn relative chaos into something that makes sense. We can be busy, but feel satisfied that we can continue to deliver high quality care for our patients. It can be exhilarating to work in a busy emergency department. However, working in an overwhelmed emergency department was not something that I wanted to experience. For me, being overwhelmed means that you can no longer deliver the type of patient care you've been educated to do. As February turned to March, I became increasingly concerned that there was a very real potential that I could find myself working in an emergency department that became overwhelmed. As many of you remember, our first COVID positive patient in Victoria was on January the 30th. The Ruby Princess docked in mid-March, and not long after that, in one shift, everything changed. I remember walking onto that shift where, like all other emergency departments, we literally divided our department into two. We had one area for high-risk COVID patients and another area for patients that screened as low-risk COVID patients. In my 24 years of emergency nursing, I have never seen such a massive change to our model of care, and especially a change that occurred in literally 24 hours. It was here, it was real, and it was all hands on deck. Staff like myself that had additional skills in ventilation or ICU experience were asked to agree to work in these areas if required. While this made sense and was a good use of resources, there was part of me that was truly frightened of working in such a high-risk area based on the images we were seeing from overseas. The day after the shift where everything changed, I had some personal decisions to make. Some of the decisions I made back now, but back in March, we had no idea how things were going to play out. All we had to compare was what we were seeing overseas, and what we were seeing was not good. How would I keep everyone I loved as safe as I could? Would I continue to kiss my kids? There were reports in March of kids having cardiac issues post-COVID. I couldn't forgive myself if I gave my kids that. And what about my parents? The research back in March was scant, but it was already telling us that the over 65s were the most vulnerable. I didn't want to transmit COVID to my parents. I made the decision that day to go and visit them and hug and kiss them for the last time until this was over. I think back then we thought that the end of COVID wouldn't be as elusive as it feels today. To be honest, being at work in March, April, and even some of May, it's all now a bit of a blur. Everything happens so fast. The emails informing us of updates to processes were constant, and I was checking my work emails twice a day just to keep up. The way we did business was changing dramatically. With the introduction of PPE, the way we worked changed again. Wearing PPE was not foreign to us. There are many indications for when you need to wear it. However, we never needed to wear it all day, every day, for everyone to wear it all shifts. I was so thankful that we had access to the PPE we needed, but that doesn't change the fact that it's incredibly uncomfortable to wear. The masks are designed to fit tightly across your face and head and are designed to prevent virus particles entering into your respiratory system. Even when you're just standing there, the material is very dense and it can be very difficult to breathe through. Even just speaking to a patient while standing still can leave you quite short of breath. It's also really hot to wear PPE. The face shield that we wear can reflect the light, making it difficult to see through at times. It's just all a lot. Interestingly, wearing PPE also produces other types of barriers. It's harder to talk to people. It's hard to hear and it's hard to be heard. Much of the communication we do in healthcare is nonverbal. The look of empathy or understanding on your face, touching a patient's arm to communicate you're not alone, I'm here for you. Even just smiling is not easily communicated behind a mask. I spend a lot of my day consciously crinkling my eyes so patients, especially the kids and my colleagues, know I'm hearing them. This is one of the only forms of communication that we're left with. Personally, I've noticed also that I'm quite dehydrated on the days after my shifts. It's difficult to drink water with all your gear on, and drinks are therefore left just to your breaks. It's just too much rigmarole to try and change everything. Another decision that was made early on was how was I going to choose to don and doff, that's getting in and out of your gear, before and after work. Many of my colleagues drive home in their scrubs, doff in their garage, place their scrubs directly into a hot washing machine load, then go back, scrub their car seat, their steering wheel, their gear stick, their footwell, basically everything they've touched in their car with sanitizer, and then do a nudie run to the shower. I made the choice to take a bag to work every day. I arrive in casual clothes, I get changed into scrubs once I'm at work, I then shower at work after my shift, and then leave in casual clothes. All this is different to how we used to do it. It's also increased your daily mental load, as you always need to be thinking, what did I just touch? Do I need to wash my hands again? Is it time to don and doff? Is it time to change my mask and face shield again? We also sign an attestation every day when walking into the hospital, stating that we haven't been in close contact with a COVID positive person, we haven't been overseas recently, we haven't had any new symptoms consistent with COVID. We also have to sign in and out of our tea rooms when we go on breaks so that our movements can be traced if necessary. All of these new layers of complexity are designed to further protect us, and for that I'm very grateful. It's just changed the way that we do things at work. There are definitely some positives to working as a nurse in an ED during a pandemic. There's very few cars on the road on the way to work, although that's changing a little bit now. McDonald's was offering free hot drinks to emergency service workers for a while there. The emergency department's super clean because we've got lots of extra cleaning staff on. Also, I've had multiple thank yous from the community, and it feels really good to be acknowledged for the kind of work that you do. It's hard to summarise what my lived experience been as a clinician, working through very much in it, and perhaps we need further time to pass before we can truly reflect. I look towards my future in nursing and I'm unsure how it's going to pan out, although I'm fairly sure that I'm going to be wearing that horrid mask for quite a while longer yet. Thanks, Deb.
Thanks, Vanessa, that's great. It's just an amazing experience to hear what it's like to actually live it every day. In the face of COVID, our nursing students have really shown exemplary resilience. At-home study is not really what they signed up for at the beginning of the year, or in fact in the following years, but they continue to progress through their courses and stay on track. Many of our students have had a unique placement experience that will shape their careers forever. Our academic staff adapted their programs at a cracking pace in consultation with the wider sector. Everything had to move so very quickly to accommodate the new changed circumstances. Our teaching practices are world-class, we hope still. In fact, I'm sure they are still. We are ranked 14th in the nursing world-wide QS rankings and #1 in Victoria for teaching quality and student experience. And we really want to maintain those high standards, even in a pandemic. Our second speaker, Associate Professor Julia Morford, will highlight how our university and health sector has problem solved and supported students, healthcare partners and teaching staff to stay safe, reimagine learning while living through a pandemic. Thank you, Julia.
Thank you, Deborah, and good evening, everyone. As Deb said, I'm the Director of Education at Monash Nursing and Midwifery, and I'm also the National President of the College of Emergency Nursing Australasia. Here at Monash, I'm responsible for all of our courses, and specifically I teach into the emergency nursing stream and also teach our final year nursing and midwifery students. We have 1,750 students enrolled in 3 courses that lead to registration as a nurse or midwife. These courses combine theory and clinical skills, and students learn in both the university environment and in the health services. We combine workshops, clinical labs, medium and high fidelity simulation, and online learning, including virtual reality, and of course this year, Zoom. Every student must complete at least 800 hours, which is equivalent to at least 100 days of clinical placement in the hospitals or in healthcare. And students in nursing and midwifery, the double degree, complete double that. This equates to more than 70,000 clinical placement days every year from students in our school. Students faced a range of challenges and difficult decisions this year, and some of those are similar to the challenges faced by other community members: isolation, loss of paid employment, homeschooling, and studying online. And of course, our students also had the challenge of entering the health services. As Vanessa has indicated, information and plans were changing daily, and sometimes it felt like hourly, and our team worked long days to respond and provide students with as much support as possible. We knew that despite the challenges we were all facing, this year's graduates and those in the years behind would be more needed than ever, and so we've been careful and considered and flexible in all our decisions to support students through their study as much as possible. When I cast my mind back to those sunny and, in my case, naive days of January, when COVID was an issue that was affecting our students who were offshore, but didn't seem to be a problem for Australia, and the university decided to start the semester a week late to enable students who were arriving from overseas time to isolate in their homes here in Australia for 2 weeks prior to classes commencing, I couldn't have imagined what was to come. In February, we introduced a more flexible model of learning, enabling students to choose to study online as they needed to. Because of the timing of our clinical placement, on-campus classes started in February, and the situation continued to change almost daily, and by March, all our classes were online by default. With so many changes, there was a lot of uncertainty, and we were all grappling with how to get this right, and we were really breaking new ground as we managed educational changes as well as changes in health service policy on that daily basis. With so many changing messages, in addition to the online classes, we set up weekly course-level webinars to enable students to get an update on changes, raise their concerns and questions, and to have a single source of truth. Summaries of these were emailed to all students to ensure consistent communication. Common questions at the forums focused on clinical placement and whether students could still attend. Most health services continued to support student placement throughout semester one and provided students with appropriate education and personal protective equipment. Our students were given the choice to opt out and complete placement at a later date, and a small number, just 3%, needed to do that because of their personal circumstances. Usually that either they or a family member were more vulnerable to COVID and therefore could not risk the exposure, or that they became the sole breadwinner in the family and needed to work more paid hours. But the majority of our students were focused on being able to complete placement and wanting to make a positive contribution. This was really reflected by the repeated questions in the forums that focused on the surge workforce and the opportunity to work as a registered undergraduate student of nursing, or Rosso. Most of our local partner health services were employing more students in the Rosso roles, and many of our students deployed into these, helping staff essential wards in Victorian hospitals and really making a positive contribution during this crisis. We've always prided ourselves here on the relationships and the support we build with our students, and we were conscious that this new situation would be even more critical and that a personalised approach would be needed. Student clinical placement commenced on the 2nd of March, which was just as the COVID numbers in Victoria really started to increase for the first time. And this obviously increased the risk of COVID in the hospitals. And by late March, we had students exposed to either known or suspected COVID whilst on placement. And we were developing plans to support those students. In this first wave, we had between 10 and 15 students who were a close contact of a COVID positive patient without the right PPE at the time because they weren't known to have COVID. And all of those students were isolated for 2 weeks each. Similar to the concerns that Vanessa's described, questions in the weekly forum turned to how students could protect themselves and their families, and we spent a lot of time helping students prepare for these concerns. Student placement is a 24-hour-a-day, 7-day-a-week experience, and we had a team taking phone calls from students day and night, drawing on our own clinical experience and coaching them in how to be safe when they returned from a placement with possible exposure. This included calls after hours to describe how to safely decontaminate in the garage before entering their home, and often providing emotional support. We also, as I said, had students who were required to go into self-isolation, which brought new challenges. Many students live in shared accommodation, so our staff were coaching them on how to clean the shared bathroom after they'd used it, and speaking with their flatmates on how to protect themselves whilst also supporting their friend by leaving meals at the door, things like that. We also supported many students into Hotel for Heroes. Some students were unable to work because of their isolation, and we ensured they were linked with financial supports, both via Monash University and later those government supports. We were also making 2 to 3 phone calls per week to each student who was isolating, checking on their welfare, linking the students with the Monash Campus Community Division, who manage welfare and support for all Monash students and staff. And this team delivered a lot of emergency food packs. They allocated support workers for those who needed it and provided further emergency financial support. The second wave had a bigger impact on our students, but we were also more prepared and there were better government supports in place. In the second wave, we had 52 students who had to stop clinical placement for about 3 weeks as the health services tried to control the risk and the spread. Again, students received individual support as needed, but they seemed more prepared this time. We had another 50 students removed from placement for testing because of symptoms, which may have been community acquired, but all were able to return to placement after a negative result. And this was another change from semester 1. In semester 1, even if they had a negative result, they needed to isolate for at least 2 weeks. I'm genuinely proud of the response of our students that they've demonstrated over this difficult semester, stepping forward into this crisis and balancing online study, work in the clinical setting and their personal lives. And I believe we have a resilient cohort who are committed to our profession and the community. They've been prepared for infection control and disaster management better than any cohort before them. And I've seen them mature really rapidly in the classes I teach, and I'm confident that our future is in good hands. I also should acknowledge the fantastic team we work with, who have worked very long days to complete risk assessments, map clinical placements, answer phone calls from students, or deliver evening classes to work around students who are homeschooling. The efforts of this team have been the basis of the success of our school this year, and I thank them. And thank you, Deb.
Thank you, Julia. Good insights into the busy year we've had to date. In addition to preparing registered nurses and postgrad degrees, nursing and midwifery is offering hands-on education to improve the lives of our most vulnerable. In August of this year, our infection control experts teamed with our innovative educators to design and deliver face-to-face PPE education to workers in residential aged care. Our team has already educated almost 3,000 staff across 70 aged care facilities in an innovative hands-on model. Further classes have now been delivered by the request of the Australian Defence Force, and we're being approached by other groups to provide the same education. Associate Professor Helen Rosso will speak to her involvement in aged care to support the response of COVID in this sector and the impact of this agile education program we established to address an identified need. Thank you, Helen.
Thanks, Deb, and good evening, everyone, and thanks for joining our webinar. And as Deb said, I'm a registered nurse and I'm an academic at the university. And my focus is on safe and quality care for older people. And look, I no longer have a clinical role in aged care, but I remain closely engaged in residential aged care. So I'm able to understand all those key issues, the concern and the challenges, and to be able to bring that to how I can contribute through evidence-based solutions to support older people and the staff that care for them. And I keep those connections through my work at the university, my research and my service in the sector. And look, on a personal note, I know what it's like to work in aged care. I was a registered nurse in there, a nurse in charge working for a long time. And I also know what it's like to be someone who has a family member in aged care at this point in time in COVID-19 and not able to see them. My mother is in an aged care facility right now in England, I can't travel to go and see her. And even if I could, I cannot actually physically go into the building to see her. So I understand the anxieties this raises for family members. And it's really important that I have that insight. COVID-19 has been an absolutely huge impact in residential aged care homes in Australia, and particularly here in Melbourne. It's had a severe toll on our residents and family members because of being separated through those visitor restrictions. There's been the morbidity toll on residents and staff who've actually gotten sick with the virus. And sadly, we've had older people die in aged care from COVID-19. 3/4 of the deaths from COVID-19 in Australia has been people living in residential aged care homes, and most of those have been in here in Victoria, although many people died in hospital. And that really puts another lens for residential aged care in addition to the Royal Commission that we're having now. That tradition of aged care being a homely place, soft furnishings, that large communal spaces where residents encouraged to come together to engage, staff coming together, that's now changing, and the focus is on infection prevention, control, measures to maintain physical distance, staff working with face masks and shields. All that has challenges. And as Vanessa highlighted, it's very difficult, particularly in residential aged care, to have engagement with residents. It's difficult to speak to them through the mask, and it's difficult for them to hear you. So that's a real challenge. Aged care is now walking that fine line. When I worked, I didn't have to work in PPE, didn't have to, and all day, as Vanessa mentioned, didn't have to wear a mask and a shield. So how was I engaged? So really early in the pandemic, back in March, I became part of a COVID-19 crisis management team at a small aged care organisation here in Melbourne. And I'm really pleased, and I'm really thankful, and I'm really grateful to the staff, the management, that we have not had an outbreak of COVID-19. And it's a true testament and credit to the staff, the management, and the leadership of what happened there. The team formed really early in March, and it consisted of myself, the CEO, the chair of board, the senior clinical nurse manager, registered nurse, the operations director, and someone with very high level experience to manage international medical emergencies. That was a team that came together. And in this year of, the nurse and midwife, we talk about 2020, and with a pandemic overlaid, even WHO has highlighted the importance of having nurses at the center of decision-making, policy, planning. And this is so important in residential aged care. There were 2 RNs at the table for this crisis management team, and our input was absolutely valuable. It was critical. We were able to bring that clinical knowledge and lens to everything that we do. And that's really good leadership. We've met almost every week since early March. We continue to do it today, and we will continue to have those meetings with that team as we go forward into the future, whatever our COVID normal looks like. So some of the things that I engaged in this committee, we discussed the COVID-19 response plan. What is the plan for the organization? And how are we going to change that plan as the pandemic unfolded here in Melbourne? We reviewed, obviously, our PPE stock. Do we have stock? Do we have the correct amount of stock? If there was an outbreak, how would we manage, etc.? And really importantly, that staff education on infection prevention and control and the use of PPE. So well and good having the PPE, but it doesn't help if the staff don't know how to use it and use it correctly. We workshop scenarios, for example, if the kitchen went down, if staff in the kitchen were not able to come into work, how would we ensure that the residents were able to get their meals, the nutritious meals at that? Similarly, if the laundry went down, etc. But from a more care perspective, we had to really think about how do we ensure residents can have engagement through face-to-face or via technology with their loved ones. That's really important. And the recent report from the Royal Commission into COVID-19 in aged care has highlighted how important it is for older people to keep maintaining that engagement, particularly face-to-face as much as possible with their loved ones. And coupled with that, it's residential aged care. People do die in aged care. We wanted to support the older person and family members if there was a resident who was having end-of-life care. We don't want them to be separated. We want them to still engage as much as possible. So it's not a question of saying a blanket, no visitors. We had to work with what was unfolding, and that's where our clinical decision-making as RNs really comes into play. And on top of all that, it's the staff as well, thinking about the impact on the staff. They're anxious staff. The staff in this organization was so anxious. They didn't want to be the person, as they saw it, to bring the virus in, as sometimes the clinical manager said they would say. They were concerned for those older people they were caring for. They were also concerned for their colleagues and also their families, because of course they were going home at the end of their shifts. They really wanted to do everything right. And overlaying everything, what was really important for us to do was maintaining ongoing communication with everyone. That's the residents, the staff, family members, really having that good engagement and communication about what we were doing in this committee, how we were supporting them, and the decisions we made. But it wasn't just one-sided. We were also welcoming their feedback as well on things that we were doing or suggestions that they might have. And these are really good examples of how I got engaged as a nurse, and how great it is that the education that I have had, it teaches me to critically think, evidence-based practice, all about decision-making and finding the right solutions after analysing all the evidence around. And for RNs working in HK, it's really important because they represent a very small proportion of that workforce, but have an enormous responsibility and accountability for everything, including staff with very different training. So I'm not sure if people are aware, but RNs have a 3-year training right now, very different, as Deb spoke about, from what happened previously. And often it's an undergraduate degree. Enrolled nurses, another group of nurses that are in aged care, they have an 18-month to 2-year diploma. And the majority workforce are personal care workers who do minimum a Cert 3, which is around 7 months of education. And what they do is very different to what we're requiring now, which is why that education, infection prevention and control is so important. And that brings me on to something that's really close to us here in Monash Nursing and Midwifery. We're part of the National Centre for Healthy Ageing. It's a joint venture between Peninsula Health, Monash University and the community. And we're a real centralised hub for innovation and transformation of care practices. And which is why, as Deb highlighted when she was speaking, we used our expertise in nursing, aged care, education, and infection prevention and control, and partnered with DHHS to deliver face-to-face infection prevention and PPE education for all staff across residential aged care staff across Victoria. And Deb highlighted those great numbers, nearly 3,000 people trained, but in addition to that, 559 champions, because when we do that training, we want to ensure that there's sustainability. And how did we do that across the state? 19 RNs were involved, led by one of our great staff, Samantha Dix, who isn't on the panel tonight. And this is exactly what we do to get across, absolutely across everyone as much as possible. And look, we know infections are around. There have been infections in residential aged care. COVID-19 has put this on a absolutely different level. It's a pandemic, it's highly infectious, sometimes it's deadly, and particularly for the population of people that are in aged care. And overwhelmingly from our experience with this infection prevention and control education across the state, the staff are hungry for it. They absolutely want it because they want to make sure that they're doing everything correctly, that they're able to protect them, that the residents, they're able to protect the staff and also themselves. They want it. It's about keeping everyone safe. And part of that, how I'm also engaged, is the work that I do in terms of my research. Again, as a family member, difficult engaging because of access, I'm really looking at, and through some research, the impact of restricted care practices on family members, care partners of people living in residential aged care. Because we know that the impact's been quite challenging for people, but getting to understand exactly what can we take from this to make recommendations for future times when there might be restricted access so that aged care providers can support family members. So nurses, we work across so many areas in clinical and supportive care. And as a nurse academic, whilst I am outside of the clinical aspect of hands-on work, I'm very, very much involved. And I really want to say thank you to the nurses and the personal care workers in residential aged care for the work that they are doing. They need to be supported. It's a very difficult task that they're doing at the moment. And I can't say that face to face to the people who are looking after my mum, but I really want to say thank you to them. And we will continue through the National Centre of Healthy Ageing, really working with our school and aged care providers to increase the education across the sector. Thanks, Deb.
Thank you, Helen. Good insight into the aged care sector that's often been beaten up in the media, despite everybody's good intentions. Our Faculty of Medicine, Nursing and Health Sciences is also very proud of our researchers' response to the pandemic and our role in the community. Monash Nursing and Monash University, the broader faculty, has seconded experts to DHHS, and our thought leaders are closely advising government. So on that note, I'd like to introduce you to Associate Professor Philip Rosso, and Phil will share the work of the National Infection Control Expert Group that he is Deputy Chair of and the impact COVID has had on infection control. Thank you, Philip.
Thanks, Deb, and thank you for the opportunity to speak tonight. And I must say, I'm privileged to be amongst this panel, and I've been really impressed with the stories and the hard work that everybody is doing. So I'm going to take a slightly different angle, and that's the beauty of nursing, is that it's very diverse. And so I'm going to be coming from an infection control angle, and firstly talk about how I got into infection control and what interests me. So it goes back a long time ago now, when I was a student nurse and I was working on an isolation ward, and I was somewhat intrigued by the nurses who were all wearing these gowns and gloves and masks and goggles to look after these patients, and I didn't quite get it at first. And with time, after I had registered, I ended up working on the infectious diseases ward at a large public hospital in Melbourne. And at that stage, it was when we were getting lots of inpatients admitted with HIV and AIDS, with really horrible opportunistic infections. And so, given the nature of working, a lot of the time I was working out of hours, late shifts and weekends and night duty. And because we were the infectious diseases ward, we sort of became the out of hours de facto infection control go-to people. And so we would often take calls from various wards and departments across the hospital on what to do for certain infection prevention issues. And to me, infection prevention sort of seemed pretty straightforward. And once it was explained to me from a mentor who I was very grateful for, you know, the 5 factors that you need for an infection to take place. You need a pathogen, you need an infectious dose, you need a mode of transmission, a portal of entry, and you need a susceptible host. And infection prevention is about taking one of those out of the equation and an infection won't occur. So I sort of quite liked that idea. Moving forward a little bit, I worked in a number of hospitals around Melbourne in infection prevention and control. I also worked at a state level in Victoria, and also at a national level with the Hand Hygiene Australia project, which were fantastic positions and gave me the opportunity to develop some great networks. During this time, I also undertook a Masters of Clinical Epidemiology, and I was rather a late starter and finisher of my PhD, which was also in infection prevention and control. So now I work mostly as a researcher, with most of my research is focused on healthcare associated infection prevention. And I've also had a very long involvement with the National Infection Control Association, which is called the Australasian College for Infection Prevention and Control. And I'm currently the president of the college. So to my role on the Infection Control Expert Group, so in January of this year, I received a phone call from Professor Lynn Gilbert, who's an infectious diseases physician in Sydney with a long esteemed background in infectious diseases and public health, invited me to join a small group of infection control experts who would be able to provide advice to the Australian Health Protection Principle Committee. Now, the Australian Health Protection Principal Committee is the key decision-making committee for health emergencies in Australia. It is chaired by the Australian Chief Medical Officer, who at the time was Brendan Murphy, and it comprises of all the state and territory chief health officers. And occasionally they will bring in other experts such as infectious diseases physicians, epidemiologists, and public health physicians as well. So the idea was that we would be providing advice to HPPC on certain issues that they needed guidance on. In those early couple of weeks, it was a lot of effort was put into how to manage you might recall at that time we were flying home lots of Australians who were in the Wuhan province, and we had to advise on what flight crews should do, what the passengers on the plane should do, and what to do with the plane and everybody after it had landed. The other big issue at the time, of course, was PPE and when to use and what to use. And of course, that is still very much an ongoing discussion and evolving discussion as more evidence comes to light. Since that time, we have met pretty much every Wednesday afternoon for a number of hours, where we discuss our recommendations and come up with consensus on the evidence that we could find. And in between those meetings, there's always a lot of email traffic, working up various recommendations and guidance. I think it's important to point out that this group is actually a voluntary group, and we receive no funding whatsoever. And it is quite time intensive, so I'm very thankful to to Monash University and also to Cabrini for allowing me and supporting my involvement in the committee. Today, the group has grown quite a bit. It comprises of 17 members, which covers infection control, infectious diseases, state health department representation, occupational health, and also aged care representatives. Of those 17, 8 members are nurses, and that includes the Chief Nursing Officer, Alison McMillan. The other nurses in the group are all infection control experts who have been accredited by the College of Infection Control. I did a quick calculation this afternoon. I hope I haven't overestimated anybody's age on this group, but I think there's roughly about 100 plus over 150 years of nursing infection control experience on this committee, which is not bad given that I'm only 22. Recently, the work of the infection control expert group has been bolstered with a partnership with the National COVID-19 Clinical Evidence Task Force. The task force provides continuous evidence surveillance to synthesise and provide evidence-based guidelines for our group. If you do a quick search on PubMed for articles relating to COVID, you will find there's approximately 60,000 articles in your in-bin, and that increases exponentially every day. So it's literally a full-time job to keep across all the evidence, and that's what the task force does. And we are really looking forward to having them behind us to help us out with our future recommendations. So what has COVID done for infection prevention? Well, it's literally propelled it further than I ever thought it would go, and it's front and foremost of everybody's mind. It's actually great to see all healthcare workers across the board appreciating the importance of infection prevention, and that the infection prevention team has become one of their big important engine rooms of all healthcare facilities. If we keep this vigilance up, we should be able to prevent all infections forever. In the community, it has clearly increased literacy in infection prevention. I'm sure all our family members now are experts in hand hygiene and discussing PPE and physical distancing. And who would have ever thought we'd see primary school kids lining up to use hand rubs before they entered the classroom? As a nurse working in infection prevention and control during this pandemic, I feel very grateful that A, I have a job, B, that I hope my work has contributed to the safety of our community, and C, I just totally appreciate the wonderful work that many nurses are doing in Australia. So to finish up, there is a saying amongst infection control circles that infection prevention is everybody's business. And originally that was in reference to healthcare workers. But I think now we are really talking that it is about everyone. Thanks, Deb.
Thank you, Phil. Thank you to all of our panellists. So I feel they've provided great insights into the diverse work of our nurses, which was the purpose of tonight, via the lens of the current pandemic, to give you a sense of the incredible work and influence from all different perspectives and at different levels that nursing as a career offers. So I really thank you, panellists. I would now like to open up to the question and answer part of this session. And I can see that some questions have come through, so I might keep going. I'm very conscious of the time. I might start with you, Vanessa. There's a question here. Has the way that you interact with patients changed in the ED? You did touch on this, but it would be good to hear a little more, I think.
Yeah, thanks, Deb. Yeah, you're right. I did touch on this during the presentation. I might take a slightly different slant now and just speak to nurses being patient advocates. I think that really changed during the pandemic, and that's because patients aren't bringing anyone in with them. Now, that's never happened before. You always have your support team around you as a patient. You have family, a friend brings you, that's all organised, and they can speak on your behalf too. If you need something, go and tell the nurse I need this, go and tell the nurse. But without your family around you, this is a really lonely experience. Add on to that for our non-English speaking patients, and that must be just really frightening. So I think that's certainly changed. We've always been our patient's advocate, but I think we've kind of more strongly become that advocate for our patients during the pandemic. Yeah.
Thank you. Thank you. In terms of Helen, here's one about residential aged care facilities. They have a diverse workforce in terms of skill set, from laundry and kitchen staff to registered nurses and business owners and board members. They all have a role to play, but how, in responding to COVID, how have their preparedness for this role differed from your experience?
I think it's, thanks, Deb, for that question, and whoever posted that question. I think it's really important to understand, and I think that from my experience in the organisation I was involved with, it was that whole of organisation approach. And for example, the COVID response team that I was on, it goes from the board, the chair of the board, the CEO, right through to all the direct care staff, to people working in the laundry and the kitchens. It's about preparing everyone to make sure that they understand their role, which for COVID-19 was all focused around infection prevention and control. And I think given more to that as well, it's from an organization's perspective also, it's having a COVID response plan. Having the plan, but also knowing where the plan is. I know it sounds silly, but knowing where that plan is, ensuring that the staff are aware of the plan, but also how it should be operationalized. For example, it's not just for staff or these people in the organization, and that's all levels of staff, from administrative staff, clinicians, etc. But it's about all people that are coming in, whether they are workmen, people visiting, external clinicians coming in. They all have to be part of that plan. And I think it's important, one of the things that's raised, how people are prepared, is that insurance of having someone that's trained in infection prevention and control as a champion and a leader in the organization. Where I am, they have that. And for that work we're doing with the PPE training, this is what we're developing as well.
Thank you, Helen. Good insights. This one's for you, Julia. How has COVID changed the way nursing is conducted and trained for the future?
I think despite the challenges, which probably were largely related to the unexpected nature of this, there's actually been some really positive outcomes. There's not everything that we've had to do this year would we like to continue with, but there has been some really good things. So I know one of the staff in our school set up an online study group mapping activity where people who might normally not have found people in common to study with have had these online via Zoom personalised link meetings, which have really worked well for a lot of students. We already had quite a lot of content online, but we've been able to get resources to get a lot more online, and we've used 360-degree cameras to build virtual reality simulations for students so that they can do decision making and real-time tasks all from the safety of their home. I think it's increased flexibility for students. So we were already moving away from lectures, but there were still some units that had lectures, and by sheer force of not being able to be on campus in that large group, they're gone. And I don't think they'll come back. We've got much better, short, sharp delivery of recorded content, but more workshops which you can facilitate online in Zoom using breakout rooms. And I think people have become really skilled at that this year. Probably things that we might have put off that we were a bit nervous about. For myself, I wasn't so comfortable with the polls and breakout rooms, but I really feel like I've got that nailed now. And then I think the use of Rosso in the hospitals, we had them before. It started in 2015 or 2016, the Rosso role. And so some of our students were already doing those roles, but there's been a significant increase this year. And I think and hope that that has really highlighted the great capacity our students have to contribute in a paid way in the health services while still learning, still under supervision. But I think all of those things have been terrific. And then I look forward to being able to have people back face to face for some of the more skills, and just because in the end, nurses are people.
Thank you, Julia. Couldn't agree more. I do miss a bit more human interaction, I have to say. Here's a question for you, Philip. How well has a coordinated federal-state response worked in your experience?
That's a really good question. Thanks, Deb. And I'll be speaking of my own opinion on this. And I think that my response is okay. And I would follow that up with, it could be a whole lot better. And I say that because currently we have, when it comes to guidelines, we have national guidelines, we have state guidelines, we have various associations and colleges and organisations who have their own guidelines. And I know early on, and still occasionally, there is very mixed messaging coming out with regards to recommendations and guidelines. Not only is that, and that's confusing for people who are working, doing all the hard work. Apart from that, there's also a lot of duplication of work. To have all these various same groups working on similar guidelines for the same purpose, to me, doesn't make a lot of sense. And as I mentioned, our infection control group is still pretty much an informal group that's been brought together as a response. But what I think we need is dedicated resources at a national level that would provide expertise in public health and epidemiology, infectious diseases, and of course infection prevention, that would work with the Commonwealth government and state and territory governments to coordinate and support surveillance and response of infectious diseases. So it's not just for this pandemic, but for the next one, because there will be future pandemics. We need one source of truth, and we need to offer better support from a national level, I think, a stronger support and a well-funded and well-resourced support that we could then get to work with the states and territories.
Thanks, Phil. That's very important, I think. There's been a lot of debate around that area, and it's good to hear your perspective, and sounds very sensible to me. We've got a few more minutes left. There's another question here, and I think it's helpful, it would be very insightful to hear, Vanessa, are there practices you will keep doing differently in the emergency department as a result of learning from COVID?
Oh, thanks, Deb. That's another good one. Look, I think there are, and I'll probably hark back on Julia's point from earlier, and it would be the online, how much that whole world has opened up now within industry, obviously within academia, but I think, academia has always been quite good at tech and online stuff. But in industry, it's hard to get everyone to a meeting. We try and have meetings during double staffing times and things like that. But it's hard to get everyone on the floor into a meeting. And I think our mindset has changed there now. So I'm certainly joining into meetings, which I see them come up and I'm like, oh, I'm not working that shift now, I'll miss the meeting. And you used to miss it because they weren't really recorded, but now we do. We've started, because we can't all be in the same room, we are recording our meetings as well. So I can also listen to them asynchronously. So if I can't make 2 to 3 on a Wednesday, I can listen any old time. And I've even learnt too, if it's a YouTube kind of thing that we've uploaded to, or even within our intranet at the organisation, I can just put headphones on and listen to it like a podcast, so I can keep mucking around at home if that's a day off for me or whatever. So I've actually found that I'm getting a lot more involved in meetings. And I think that's something we're probably going to continue with, because we're just getting greater uptake and our messages are just being spread in better ways, I think. Yeah, so thanks for the question.
Thanks, Vanessa. I think we've got time for just one more final question. And I think it's really timely to talk about the Royal Commission into aged care. Helen, so probably you're best to answer this one. What do you think about the Royal Commission's recommendation for minimum inclusion of an infection control expert and minimum standards for infection control training? How might that be operationalised within the residential aged care facilities?
One word, yes. Absolutely, absolutely, absolutely. Because it's, as I said when I was speaking earlier on, it's not, there are infections in residential aged care. We have a population in residential aged care that are accessing residential aged care when they're sick, more and more sick. So that makes them vulnerable to infections. We know about flu epidemics, etc. And as Phil highlighted, there'll be more pandemics. Absolutely, we need to have that as a minimum one. And, I would say, more than one, because when that one person goes on holiday, what's happened? We know that champions and leadership works, and it's a role where somebody can take charge, but this should just be a dedicated person, a registered nurse, dedicated person working in the organization, fully trained as an infection prevention and control. Absolutely important. And this is how it's operationalized. It's through mandated from the government. The Royal Commission recommended. The government have said they will accept those recommendations. So I think we're going to see that happen, but definitely.
Excellent. Thank you. I hope so too. I think that's bringing us, I can just see we're right on the knocker of 8 p.m. And so I think we'll bring this session to an end, this webinar to an end. And I would like to thank our panelists, our experts who've shared their insights this evening, and those who have posed some interesting questions. I'd also like to thank the staff who have made this evening seminar possible, who work behind the scenes, in particular Shelley Ryland, Amanda Rowe and Jackie Conhetti. And I would like to highlight the Monash Nursing and Midwifery banner that's on your screen now, which should appear, well, it has appeared, I can see that now. Should you wish to connect with us, we welcome engagement from the community at all levels to contribute to our ongoing work and research. And there's some contact details on that banner. And I wish you all a happy and safe evening and long weekend for those of you who are in Victoria. And we hope to engage with you in the future. I hope tonight was very insightful. Good evening.